To this channel made for me. In this video, we will learn about necrotizing fasciitis. It is one of the most important topic which we deal in the surgery theory exam and in the viva exam. So starting with this topic, let's see the picture which I am showing here. It looks like it is a very deadly infection. So uh, by looking at the picture, it looks like it is an emergency condition which we should treat immediately. Okay, so let's start. So necrotizing fasciitis, it is an emergency condition. It is an emergency condition. Why it is an emergency condition? Because it rapidly spreads. Because it rapidly spreads. It rapidly spreads. And the group of people which are infected by this necrotizing fasciitis, they are usually the immunocompromised patients. So the person who are immunocompromised patients are like the persons which are old, the person with smoke, the diabetic patient, and the patient on immunosuppressant, immunosuppressant, the patient undergoing any immunosuppressant therapy and like steroid therapy, the HIV patient. So these are the group of people which are very prone to this necrotizing fasciitis. Okay, so these are the risk factors. So does it mean that these are only the people which are getting infected by this necrotizing fasciitis? No, it can occur in non-immunocompromised patient also. So there are a group of bacteria uh, which infect some this the patient with these risk factors and some with the patient without these risk factors. So based on the type of bacteria involved, the necrotizing fasciitis is divided into four types. Okay, so the types are, there are four types. The first one is polymicrobial. polymicrobial Polymicrobial means there are group of organisms. There is not only a single organism, but there is a group of organisms. Polymicrobial. Okay, so in polymicrobial there are non-group A. There is one group A streptococci and another is non-group A streptococci. So in polymicrobial, non-group A streptococci along with anaerobes or clostridia or E. coli. These are the organisms which are found in polymicrobial. And the second one is monomicrobial. So in monomicrobial, the organism which is most common, it is due to group A hemolytic streptococci. So we write as gas infection. Okay, group A hemolytic streptococci or methicillin resistant Staphylococcus aureus. So these are the group of organisms which are involved as monomicrobial in necrotizing fasciitis. The third one is type 3. The first one is type 1. Okay, the second one is type 2 and the third one is type 3. So in type 3, Vibrio, there is an organism called Vibrio volficus, not Vibrio cholera. It is Vibrio volficus. Vibrio volficus. This is the organism which cause type 3, and the fourth one is type 4. So it is caused by a fungi. Which fungi? Aspergillus fungi. So these are the organisms which cause necrotizing fasciitis. Now let's write the definition of necrotizing fasciitis then. Okay, so necrotizing fasciitis, it is spreading infection. It is spreading infection. It is a spreading infection of which layer? Skin, and then subcutaneous tissue, deep fascia, deep fascia, soft tissues with extensive destruction, with extensive destruction, with extensive destruction. So the place in which this necrotizing fasciitis is common, they are usually the lower limbs. Okay, so they are usually the lower limbs. So if we talk about the site, they are mostly the lower limbs. They are mostly the lower limbs, and apart from the lower limbs, it can also occur in abdomen. But if it occurs in abdomen, then we termed this necrotizing fasciitis as Meleneys gangrene. Meleneys gangrene or Meleneys infection. Okay, and if this infection occur in the groin region, perineal area, then we term this necrotizing fasciitis as Fournier's gangrene. Fournier's gangrene. So these are the two varieties of this necrotizing fasciitis. One is the Meleneys gangrene and another is the Fournier's gangrene. And according to SRB, it is mentioned that the muscles are usually not involved. The muscles are usually not involved in necrotizing fasciitis. Muscles are usually not involved. Okay. Now let's talk about the clinical features of necrotizing fasciitis. So in clinical features, actually the patient presents with fever, pain, redness, edema. So these are the complaints which the patient presents. So according to SRB, it is divided into three clinical stages. So the first one is stage 1. In stage 1, if the patient present in stage 1, then the complaint is fever. The patient present with fever, and there is edema. And the skin is warm skin, and it is tender. Okay, and if the patient present in the stage of 2, then the features will be like it will be blisters. There will be blisters and bulla formation. And if this progresses to stage 3, then the symptoms will be like hypoesthesia. The sensation will be decreased, hypoesthesia, or it can be totally absent, anesthesia. And if there will be collection of gas within the muscles or within the skins, subcutaneous, then it can form to the emphysema, subcutaneous emphysema. So it can lead to crepitus, and there can be tissue necrosis. In this picture, we can see that there is formations of these are the blisters. Okay, and these are the bulla. There is formations of bulla. Okay, blisters and bulla formations. And look, there is the disformation of the skin, and by test we can found the hypoesthesia or anesthesia. We can also found the this crepitus. If there is subcutaneous emphysema, there is erythema. Okay, and we can also appreciate edema, and the skin also look very erythematic, and on palpation it will be warm and tender. Okay, so in simple, if we are asked about the clinical feature, then at first there is the sign of inflammation. Okay, there is simply the sign of inflammation, that is that is tumor, dull or calor, river. Okay, at first there will be sign of inflammation, later it progresses to bulla and blisters, then there will be decreased sensation of skin, there will be crepitus and tissue necrosis. Okay, and if this condition progresses to the severe stage, then it can lead to features of toxemia, then it can lead to features of toxemia, which means that which means that it will be very high grade fever, there will be very high grade fever with chills, can be hypotension, there can be hypotension, and if also this condition progress to very dangerous state, then it can lead to the renal failure, then it can lead to a renal failure. Okay, and finally it can lead to multiple organ dysfunction syndrome. Okay, systemic inflammatory response syndrome, and finally it can lead to the death. If it is not properly treated, then it can lead to death. So necrotizing fasciitis is an emergency condition, and it is one of the most dangerous life threatening condition. Okay, along with these clinical features, one thing we have to know is that the tenderness which is present in necrotizing fasciitis, it is out of proportion, tenderness is out of proportion, and similarly the toxicity which is present, it is also out of proportion, toxicity is also out of proportion. And if we look the fluid which is coming out of this blisters and bulla, they looks like the dishwasher fluid. As we wash the dish, and the fluid or the water which becomes the discolor from the normal water color, that looks like similarly as in this bulla discharging fluid, so that is known as dishwasher fluid, and it is grayish in color. Okay, so by this clinical feature is complete, and now to treat this patient, to manage this patient, what we have to do is that for management aspect, the patient is coming to the emergency department. Okay, so at first we have to do resuscitation, so starting from airway, breathing and circulation, we have to manage the airway, breathing and circulation. So immediately admit the patient, and maintain airway, breathing and circulation. Open two large bore IV cannula, open the vein, and then also catheterize the patient to monitor the urinary output. Catheterize patient to monitor urine output, and we have to know the severity of this the necrotizing fasciitis. So there is one score that is known as LRI neck score. Which score? LRI neck score. LRI neck score, which means that laboratory risk indicator for necrotizing fasciitis. It is not for the diagnosis, but it is for about the prognosis. Okay, so LRI neck score is this LRI neck score. From this we assess the severity of necrotizing fasciitis, and it has some components, I remember these components as a pneumonic called, there is a very dangerous condition, so it chews the tissues. So the mnemonics is similarly that it it chews g, it chews g. So the mnemonics is chews g. So at first C means CRP. C means CRP. So if CRP value is more than 150 mg per liter, then the score is 4. Okay, and He means hemoglobin. He means hemoglobin. So if hemoglobin value is 11 to 13.5, then the value is 1, and if it is less than 11, then value is 2. Okay, similarly W means WBC count. So if WBC count is 15,000 to 25,000, the value is 1, and if it is more than 25,000, then value is 2. And CHEWS, S means sodium, S means sodium. So the value of sodium, if it is less than 135, then value is 2. And the last one is glucose. So if glucose value is more than 180, then value is 2. One thing I miss is that there is choose CG. Okay, so the C is creatine. So the C is creatine. If its value is more than 1.6, then its value is 2. So this is the LRI NEC score. And if the total score is more than 8, then it has very bad prognosis. Okay, so if the total score is more than 8, it is very severe, and if score is 6 to 8, then it is moderate, and if score is less than 6, then it is good. So based on this, we estimate the risk of necrotizing fasciitis. We have admitted the patient, air breathing circulation is maintained, IV cannula is opened, and patient is catheterized to monitor the urine output. Now what we do, we give antibiotics. Okay, so we give antibiotics. Which type of antibiotics? We give broad spectrum antibiotics. We give broad spectrum antibiotic initially, and later on we shift to the specific antibiotic according to the culture and sensitivity. So broad spectrum antibiotics followed by antibiotic depending on culture and sensitivity. So for culture, what we send the fluid. We send the fluid which is coming out of the area of infection, and we also send blood, we also send urine. Okay, we also send the culture of pus. And the antibiotic which we used, usually they are high dose penicillins, and clindamycin, high dose penicillin, clindamycin, third generation cephalosporins like ceftriaxone, third generation cephalosporins. Okay, so these are the antibiotics which you use during the treatment, and these are all the broad spectrum antibiotics. And apart from this antibiotic, we have to also control the diabetic. So management of diabetic is also necessary, control of diabetes mellitus. And there is a very used tissue necrosis. So what we do, we debride the tissue. So aggressive tissue debridement, aggressive tissue debridement. Aggressive tissue debridement. And once there will be formation of the healthy granulation tissue, then skin grafting will be done. So once if healthy healthy granulation tissue will be formed, what we do skin grafting is done. And during the management of this necrotizing fasciitis, during resuscitation, if airway cannot be maintained by simple maneuver, then we have to also do the ET tube intubation. Okay, and similarly, the IV fluids, blood transfusion, it can be necessary. And hyperbaric oxygen is also given in high pressure with 100% oxygen in 2 to 3 atmospheric pressure, which helps in reducing the mortality to 10 to 20%. So with this I have completed the necrotizing fasciitis. Hope you like the video. Please share this video to your friends, and thank you for watching this video.